This is a technique video for the modified Lapidus procedure. We present a case of a 60-year-old woman with a Hallux valgus deformity of her right foot. The rightmost image demonstrates subluxation of the sesamoids on a coronal weight-bearing CT scan. Incisions over the medial eminence, first web space, and first tarsal metatarsal joint are marked. An incision is made over the medial eminence. A small medial eminence resection is then performed. The lateral capsule is then released through an incision in the first web space. The adductor tendon is not fully released. The great toe is manipulated so that the deformity can be corrected. An incision over the first tarsal metatarsal joint is performed. In this case, we have used the bovie to mark the dorsal aspect of the first metatarsal and medial cuneiform in order to demonstrate derotation of the first ray. The capsule over the first TMT joint is opened. An osteotome and lamina spreader is used to remove the cartilage. This helps to avoid resecting too much bone during the bone cuts and over-shortening the first ray. After mobilizing the first TMT joint, we have demonstrated how correcting pronation of the first ray allows the subluxated sesamoids to reduce underneath the first metatarsal head. The base of the first metatarsal is then cut perpendicular to its shaft. Here we have marked the medial cuneiform resection, ensuring that we take a small wedge that is wider laterally in order to correct the inner metatarsal angle. Be careful not to excessively plantar or dorsiflex the first ray. In order to fully correct the IM angle, a small amount of bone may need to be removed laterally from the metaphyseal flare of the first metatarsal. Using the line we drew before, we can demonstrate how we have changed pronation of the first ray. Meticulous joint preparation is performed using a 1.6 K-wire. Graft can be used to assist fusion of the joint. The first TMT joint is then temporarily pinned using K-wires. The capsule of the first MTP joint is sutured together in order to confirm preliminary alignment on fluoroscopy. A burr is used to allow the screw head to sit flush to the bone. The distal proximal screw is then placed in a lag by technique fashion using a 2.9 mm drill, followed by a 4.0 mm drill. A second 4 mm screw is then placed in a lagged fashion. The capsule over the medial eminence is then formally closed and the decision is made whether to perform an osteotomy. In this case, we did not perform an osteotomy. Calcaneal bone graft is then obtained by making a small incision laterally over the calcaneus. A 4.5 millimeter drill sleeve is then used to obtain dowels of bone graft. These are inserted in the burr holes made in the first TMT joint in order to assist with fusion of the joint. The capsule over the first TMT joint is then closed. Final fluoroscopic images demonstrate good correction of the IM angle and hallux valgus deformity. Postoperative weight-bearing CT scan shows reduction of the sesamoids under the first metatarsal head.
All right, so just in terms of healing, we've done kind of a silly study that got published only in our hospital's journal, but looking at healing rate after a Lapidus, and in general, the healing rate is quite good, even with cross screws. Although these are patients that weren't allowed to put weight on for about 5 or 6 weeks. This is another study that looked at healing when you did a plate and earlier weight bearing. I think it was probably 2 weeks as well, but again, a pretty good non-union rate. You start worrying in patients who have other comorbidities and as they get older, but in general, pretty good healing rate. Here's my patient now. Notice I throw in the plate. I'm going to show you some more slides on that in a second, but this plate in screw construct has a screw that goes on the bottom, which helps compress that the plantar aspect of the joint down, because one of the things I worry about is it elevating at the bottom. And notice the screw, it's the first thing you put in, by the way, goes into the middle cuneiform, not the medial, but the middle. And I really find that it helps hold that metatarsal over so that later down the line, if it's taking some time in healing, it's not going to let it slip out. And then the plate goes dorsal medial. It's a locking plate, has 2 screws proximal, an oblong screw for compression, and then the final 2 distal locking screws. I'll show that in a second. Here is what the sesamoids look afterwards. So nicely reduced in their respective sulcus, right underneath the metatarsal head. And here's what it looks like on a lateral view. And here's the healing of that bone. You can see it's healed very nicely in this case. Here's how I do the plate technique. Everything else stays the same, what I just showed you, which is why I don't have another video, but I pin it provisionally. This case, 2 wires from opposite directions. This wire is how we first aim, direct, and guide our cannulated drill to put in that plantar compression screw. And then after that's in, put the dorsal medial locking plate. You lock the 2 screws proximal. This screws an oblong hole for compression, and then finally finish the last 2. Here's what it looked like in the operating room. And another case that I'm showing, nice opposed joint, by the way. And then here's what it looks like clinically. So it's not minimally invasive, but I've been pretty happy. The other technique that I was mentioning was this Lapiplasty technique. And it dials in a lot of these concepts and helps you try to do that. Again, I have more confidence in myself having done this a number of times, but you can use the guide. It has a little device to help rotate, figure out how much you're rotating, and then compress them together. It has a guide to make your cuts, and ultimately they do their fixation with these 2 small 90-90 locking plates, which have pretty small screws, 12 to 14 millimeters, but just another variation on the theme. One criticism I get all the time for Lapidus is you're going to fuse that joint. You worry about activity level after in those patients, and I have not found that to be true. In fact, we published a study looking at sports activity in a relatively young group of patients. I think it was under 50 years old after Lapidus. And the truth is, with our survey, most patients are back to just about any sport they want to do. And a lot of it just depended on what they did pre-op. The Lapidus, probably like other procedures too, decreases foot width by about 1 or 10 millimeters, 1 centimeter. And in the United States shoe size equivalents, that's about 1 shoe size. But this was a study we did with weight-bearing CAT scan as well. So, here's just where I want to bring up a little bit about how we're using weight-bearing CAT scan to understand pronation. And Callum said it very well at the beginning. It's not what started the thinking about rotation, because as Charlie's article showed very well, it's been at least studied for years, but where we've really been able to see it is with weight-bearing CAT scan. So we published this first study last year looking at what the effect of the Lapidus procedure was on pronation of the first ray. And a lot of the work that we've done was based on a collaboration I had. I have a resident here, Matt Conti, who's going into foot and ankle surgery as a career, whose father actually is at the University of Pittsburgh. And he had a way that he was using with this software to measure pronation of the first metatarsal, and we got all the weight-bearing CAT scans here at our institution, and then he would analyze them. He's a pilot, an aviator, so he was very used to these aviator terms of yaw, roll, and pitch, which are similar to, rotation, varus valgus, and dorsiflexion, plantar flexion. And basically, they had this pretty painstaking process where they would define axes of the bones that were also identified on their software, these CAT scans, and they would compare the rotation, which they called yaw in aviator terms, to the second metatarsal. And basically what we found is preoperatively, before our bunion surgeries, patients had a mean preoperative pronation of about 29 degrees. Post-op, it went, and this is just me doing the procedure like I thought it should be done without really measuring any angles, but post-operative was about 20 degrees. And so the improvement was about 8 to 9 degrees really on average. IM angle in those cases went from something pretty large on average to something under 9, which is normal. And the sesamoids in general were reduced, although what was interesting in that study is that we did not find a direct correlation between sesamoid positional reduction and the pronation, which you'd think there would be. Now, that method's pretty difficult, as I said before, so we try to come up with an easier way to measure pronation just based on our PAC system at the hospital. So we compared the computer way from the University of Pittsburgh, which is method 1, to what we were calling the triplanar angled pronation, which is using the second metatarsal reference. And you can also use the reference to the floor, by the way. The problem with the floor is that you then can start taking, or you're not taking into account other issues that you might have with the foot. And I can't show it all, but we take the axis down the first metatarsal, we find the axis down the second, which is this kind of beige highlighted area. We define an axis with the computer down for the first metatarsal, for the second, but the first metatarsal, we draw a line along the sulci on the bottom, and then come up with what was our pronation, triplanar pronation angle compared to the second metatarsal versus the floor. And here's the data, but long story short, we found actually that the two methods were not necessarily correlated. And interestingly, the new parameter, the triplanar angle pronation measurement, which is an easier measurement, actually did correlate with sesamoid position. So it's probably a better way to measure it. But you can see there's uncertainty what even is the best way to measure pronation, which makes deciding what surgery to do and how much a little bit more difficult. So in the future, we plan, and actually this is a study in submission right now, but we're understanding how patient-reported outcomes correlate with pronation, because at the end of the day, if pronation doesn't make any difference in outcomes, then why even bother with it? So we've looked at 40 patients, took pre-op and post-op patient-reported outcomes, which are the PROMIS outcomes that we use now as part of our registry, and compared that with improvements in pronation. And basically took 3 groups: those that we didn't correct pronation very much, those that I corrected moderate pronation 2 to 8 degrees, and then substantial change. And what we noticed is the best clinical results were in those patients that had a moderate change. Although if you had moderate or substantial change, you also had a decreased risk of radiographic recurrence. So there's something to be said about being able to correct pronation in terms of it not coming back. Just a few cases here, and then I'll turn it over to Emilio, but a 58-year-old female, similar to the cases I showed before, where pretty large bunion, luckily no lesser toe pathology, used the same technique. I corrected her bunionette, actually, maybe to go back to that. She had a pretty large bunionette, which I don't commonly correct at the same time, but in this case I did through an oblique osteotomy, but used the same technique. I ended up throwing an additional screw because my oblong compression screw didn't give much purchase, and I used an Aiken osteotomy as well. And you can see, and this is a small version, sorry about that, but the sesamoids go from being sublux to reduced, which is usually a very good indication. Here's my CAT scan as I scroll through it, and you can see the sesamoid on that lateral view reduced. Most importantly, the bone is completely healed. Another reason I like to get the CAT scan around 4 or 5 months, complete healing. And then I thought maybe I had the coronal, but I don't have that. I'll just go on to the next case. Another 65-year-old female, moderate bunion, no lesser toe pathology, same concept, correcting rotation. You can see how improved the sesamoids are. Here's her sagittal view, again showing the healing, first metatarsal position. Maybe I'll skip ahead of that a little bit because it's on the other side. This case, actually, notice the joint didn't heal completely right off the bat, and I had to follow her a little bit longer. I let her put weight on it 2 weeks, but eventually it healed. There was enough healing to be stable. So with that, again, I'd like to thank the British Society for having me. I look forward to hearing what Emilio has to say, as we always do, and to any questions that you have afterwards. So thank you.
Hello, I'm Emilio Wagner. I'm from Santiago, Chile, and I'm going to talk about rotational osteotomies in hallux valgus. So it's an honor to be here, and I hope this will be an interesting time to discuss some ideas. So these are my disclosures. I'm co-designer of the promo osteotomy, which I will mention in a few minutes. So let's start saying that since decades, hallux valgus has been considered to be an uniplanar problem. So just mainly we were measuring the intermetatarsal angle, so to measure the metatarsal varus, and then we were measuring the MTP angle, so in between the metatarsal and the first phalanx. And that was mainly the study we were doing. But what about the sagittal plane? So we learned that patients with some instability of the medial column, especially patients with a severe hallux valgus, patients in which there was already a failed operation, or with an asymmetric flat foot, we did observe changes in the sagittal position of the first metatarsal and really of the whole medial column. So this was another plane of the deformity we learned to look at. So we have the transverse plane and the sagittal plane, but we still were and we are faced to an unsolved problem, which is the relapse rate. So if you look into the literature, depending on the limits you give to yourself, the relapse rate can be as high as 70%. So what are we missing? So I like to show this picture from Prince William, in which clearly we are missing one point of view. And if we don't see it, we may get into trouble. So from this idea and from some previous studies, we knew that rotation was present in the first metatarsal. So these are coronal plane changes. And I will show you why it's present in almost every hallux valgus case. We know, and you can see the references in the slide, that it's associated with recurrence and arthrosis. And thus, it makes sense that if we re-rotate the metatarsal, that should help decrease recurrence. So if you look at this case, a very common, mildly symptomatic hallux valgus case, on the left side of your image, you can see that the silhouette of the lateral aspect of the metatarsal bone is normal because you can see a small angle, which I'm showing there with that orange line. But if you take a look at the right side of the image, that lateral silhouette is not angular, it's rounded. So that's not normal. So if you start looking at your own patients, you will see that almost every one of them have the same appearance, a rounded lateral head. So this has to make us think, what are we looking at? So if you take a plastic model and draw this silhouette on the left side of the slide of a normal looking metatarsal bone without any degree of rotation, and then you apply to this same plastic model 20 degrees of rotation, and you draw the silhouette, you can see that they are not equal. You have an angular silhouette on the left, a rounded silhouette on the right. And if we superimpose some radiographic images, we can see that on the left, a non-rotated metatarsal bone has an angle, but on the right, a rotated metatarsal bone will have a rounded silhouette. So if we look at a rounded metatarsal head, it's because we're looking at the metatarsal condyle, and it's due to rotation. If we see an anatomical specimen, we can see the same appearance. From left to right, no pronation on your left, intermediate pronation at the center, and on the far right, that metatarsal is severely pronated, and the orange line shows the lateral silhouette of the head. That silhouette is what you will be looking at on a regular AP X-ray. In 2015, indeed, this situation was studied, and within hallux valgus patients, there were four possible situations. The two upper ones were without pronation, but you could still have hallux valgus, and you can see it's about 12% of cases. But 87% of the cases, of the hallux valgus cases in this article, had pronation, and you could have or not subluxation of the sesamoids. So if we accept there is some rotation of the metatarsal bone, or I should say of the medial column, how to estimate it? If you have a weight-bearing CT scan as the upper image on the right, it's easy, but it's not widely available. The axial sesamoid view is of some use, but it's not weight-bearing, so it really doesn't give you a good information. On the lower right, I'm presenting to you a Bernard view, slightly modified, and this view has weight-bearing. You could see the position of the metatarsal and try to estimate the rotation. But the problem is that you need to place the bone exactly perpendicular to the film. And that will depend, obviously, depending on the intermetatarsal angle. So this view is a good one, but it's difficult to have a perfect one. This is why we sort of designed the estimation of the pronation just taken from the AP X-rays of the foot. So as you can see on your left, if you can see a corner on the lateral silhouette of the metatarsal head, you can estimate that is a mild pronation under 20 degrees. If you see a semi-rounded or completely rounded silhouette of the metatarsal head, we know that it is sufficiently pronated, so significantly pronated. So this is a very easy way to say if you have some pronation to take care or not. Now, is the metatarsal rotating? As I was saying, is the whole complete medial column. So I have to say to you that it happens in the whole foot. And we have to remember that the apex of the deformity is not at the first TMT joint. It's far more proximal, as you can see on that slide. So we did a study, a cadaveric study, a multi-segment model, in which we tried to answer a question: which medial column joint was playing the most important role generating an hallux valgus deformity? So this is a novel cadaveric model in which we applied some axial load and some pronation through the tibia using internal rotation. And you can see these fluorescent markers, and we used high-speed infrared cameras to measure all the changes in between the segments. We added on every specimen we examined 3 different damages. The first damage was in between C1, C2 and C1, M2. The second damage was between the navicular and the cuneiform, C1, C2. And the third damage at last was the damage of the first TMT joint. And we observed the changes in the position and motion of the segments. What were the results? Well, in frontal plane alignment, which is what this talk is about, so rotation, you can see that the biggest statistical significant changes are in the medial columns, which correspond to the ones generated by the second damage. And this damage corresponds to the navicular cuneiform joints. So this is very interesting because apparently the navicular cuneiform joints are the most responsible for frontal plane alignment changes in hallux valgus. So, okay, let's say the medial column is rotating. I hope I'm convincing you, but who cares about this? So I was searching for some old x-rays of patients. These are all mine patients. And this lady, to me now, it looks like she didn't have any rotation. And after 5 years, she was having a very good result. So I was happy. I'm a good surgeon. Imagine how good it looks, doing a scarf and an aching. So then I found this another case, and I now observe that the lateral aspect of the head is slightly curved. So this is moderately pronated, and which is the result of the 3 years recurrence. So you can see that the curvature of the head pre-op and post-op is pretty much the same. So a classic scarf does not correct pronation. If we see another example, again, older cases with a rounded lateral aspect of the metatarsal head. In this case, I observed recurrence only after 1.5 years. And as you can see, I tried to rescue this with this horrible aching osteotomy. Now, finally, another word regarding rotation. This is a patient in which, to my eyes, I don't see any change in the lateral silhouette of the first metatarsal head. I did a scarf, which at that moment was the surgery I think it worked the better. But after 2 years, you can observe the changes, and you can clearly see there is a moderate recurrence, and you can see the angle and the silhouette of the metatarsal head. So that has changed, and there is some pronation now, which was not present at the beginning. So what is this being explained by what is changing? So you can see on the lateral X-ray view, if I draw the dorsal silhouette of the metatarsal head, clearly I had some troughing in this case. And probably due to the troughing, some rotation was produced. So this is another option of some failure you can observe if you observe enough your patients. So I have to say that pronation is pretty much accepted now to be one of the most important recurrence factors. and it makes sense that if you correct pronation, it should help to decrease recurrence. Now the question is how to correct it, because as I said, it can be present along the whole medial column. But we have to correct the hallux valgus, and we're not talking here about symptomatic flat feet. These are symptomatic hallux valgus patients. So the question would be if we can repair the ligaments in some reliable way, and you know the answer is no. Should we fuse all the involved joints? Probably Scott will speak or has spoken already about the Lapidus, which is one way of approaching the problem. But if you try to preserve the joints, then we get into the osteotomy world. And we already saw in my examples that a classic chevron and scarf will not correct pronation. So what do we have to do? We should try to get them to produce rotation. So you can modify the chevron with a resection of a 2 to 3 millimeters medial wedge, and this has already been published. And I can tell you, I did a small calculation, and if you remove a 3.5 millimeter medial wedge, you can correct about 20 degrees of pronation, which is a lot. The same modification, you can introduce it to the scarf if you like it. So besides correcting a lot, and you can correct almost every aspect you wish in the bone, if you resect a medial wedge, you will be able to correct also some pronation. Now, evidently in chevrons and scarves, we may get into trouble if we remove bone stock, and we may increase some risk of troughing. Some other options going MIS, obviously if you do a percutaneous chevron, which is the classic mica, you can correct a lot, but it's difficult to correct pronation because you have a chevron cut. That's why for mild and moderate deformities without significant rotation, we prefer to do a PECA, which is a transverse distal osteotomy, which can also correct a lot. But as it is a transverse osteotomy, you can correct pronation. You just stick a K-wire on the metatarsal head, and then you can play with it and rotate it. And these are just classical images for an MIS technique, which all of you already know. But this is a transverse osteotomy, which has this potential to correct pronation, mild pronation deformities. If you want to be more precise and you have a moderate deformity, you can go proximal and you can do a promo osteotomy. This osteotomy works doing a cut which goes on an oblique plane, which is precise, and will correct pronation and varus using just one cut. I can show you an example. This is a classic hallux valgus case with about 15 degrees of IMA angle. And we use this table in which we combine the IMA angle and the pronation. So in this case, we estimate it to be moderate, and the table suggests to use a 42-degree osteotomy. So that is translated with a jig in that precise angle when you do the osteotomy. So we mainly go medial. We use a hybrid sort of approach, going open for the promo, which uses a plate, and you can do poke osteotomy or poke incisions for the exostectomy and the aching. So we use a reference wire which goes 1 centimeter distal to the TMT joint. It goes parallel to the floor and 90 degrees to the metatarsal. This is very important. Then you use a small jig, which is a positioning jig, in which you replace one wire with a second one, which will allow you to be precise in correcting the pronation. Next step is to do the cut, and for that you use this osteotomy jig and you choose the correct hole which corresponds to the 42, in this case 42-degree angle osteotomy. So you can see here in the video we are replacing the first positioning jig with this other one, which is the osteotomy jig, which is fixed to the metatarsal equator. And then you have to just go ahead and do an osteotomy, which is an incomplete osteotomy. The last step of this technique is to replace the distal wire with a new one with the amount of degrees to be corrected, the amount of rotation to be corrected included. So you just use that jig and replace one wire with the, let's say, the one which will correct the rotation one. So there we are replacing the original K wire. We're choosing the hole which corresponds to the amount of rotation we want to remove, and we find it, and you can see there in the video, and we exchange one K wire with the other one. So finally, we complete the osteotomy, and you can rotate it as you wish. This is a video in which you can observe the result of this osteotomy, in which through the cut, through rotation of the distal fragment, you correct the varus of the metatarsal bone, and you correct the rotation distally, and you can see how nicely the position of the sesamoids can reduce themselves back to its place. And we use always a bone clamp to help us to achieve the desired correction. You can see both K-wires are aligned on the same plane, and then we fix it temporarily with K-wires. And then we use a small plate. This is an intraop picture, maybe not of the same patients, but to show you that we use K-wires to fix it in a temporal way, and then we replace the K-wires with a plate, which is the one you're looking at now. There are special cases. Obviously, let me show you just one of those. This is a 50-year-old female patient with some laxity. You can see that she has a mild flat foot, non-symptomatic on the right side, and a slight elevatus of the metatarsal bone on the left. She complains only of the hallux valgus, worst on the right side. And if you imagine the cartilage of that joint, that's not an asymmetric subluxation as it was called some years ago. You can imagine that the DMAA angle is completely abnormal. So probably in juveniles, we can see a true dysplasia of the metatarsal head. So you have to deal with this. If you only correct it from the proximal aspect of the head, you will end up with a very distorted distal metatarsal articular angle. So in this case, as the deformity was too big to be corrected by a chevron, we used a promo technique in the proximal aspect of the metatarsal bone. We added a biplanar chevron, and on the right side we added an aching, and on the left side it was not needed, as you can see. So these are just special cases with this type of solution. So in summary, we can do a lot with rotational osteotomies. There obviously is a limit. If you have a pathologic medial column instability, we still don't know if this instability comes from the TMT joint, but you know the Lapidus go and tries to correct the deformity at that level, but I already showed you that probably that's not enough. Probably there are many joints involved in this instability. As you can see on the right, there are some percentages, and those are the percentages of the techniques we use right now: 25% MIS, 45 chevrons, and 20-something promos. What I only want to tell you is what is pictured now on the left bottom part of the slide, which is don't see every problem as a nail. They are not the same. So every hallux valgus is different. That's why we think you need a specific solution for each of them, and we don't think it's correct to correct every hallux valgus with just one technique. Thank you very much.
To begin with, I just wanted to ask about non-union rates to both of you. You know, is that an issue? Traditionally was an issue with the Lapidus in particular, but so it's Scott first. Have you noticed that? And then Emilio, what about the promo?
Yeah, so it's the number one thing I worry about. As I showed with the literature, it doesn't happen in a huge percentage of cases, but it's enough to have to worry about. And it does change my post-op protocol, and it also depends on the patient. So I've noticed in my 20 and 30-year-olds, it heals just almost all the time. Maybe my 50 and 60-year-olds, you have to go a little bit slower. So what I'm doing now is those younger patients, probably, like I said before, 2 weeks, not putting weight on it. If you're in your 50s or 60s, I'm going to probably go 4 weeks. And then somewhere in between, just decide on the health of the patient, like their nutritional status, other risk factors. But I will say that the plate and screw have been helping me because you get much better fixation and compression. I'm hoping to do a study at some point to prove this, but I think that's helping me get it to heal and allow earlier weight bearing. Yes, you have to worry, but there's things you can do.
And before I go to Emilio, can I just ask you what the regime is, which links in with this? How early do they weight bear?
Yeah, so for most patients now, I just showed you my age distinction, but I will have a splint on them at the surgery. So no putting weight on it, no weight for 2 weeks. At 2 weeks, I then let them start progressing their full weight. And usually that happens over 3 or 4 weeks in the boot. So it's not all at once, but it's progression. And then usually by about 3 months, they're doing pretty well, not completely normal, but back to at least progressing to all activities and sports. And I'd say most patients around 4 or 5 months are back to everything.
Yeah. Emilio?
Yeah, regarding the rehab, I think we're managing the same times as Scott regarding the promo, because we haven't seen any non-union, but we're very aggressive as culture, I may say. So everybody asked you to be very fast in weight bearing, and we did very fast weight bearing about 3 years ago, and we had more than one dorsal malunion of the promo. So no non-unions, but you may get dorsal malunions. So we protect them for 2 or 3 weeks, and then we allow them to put weight on the sole of the foot with a hard stiff post-op shoe. And let me add that I also do some Lapidus, and I have to learn from Scott, because my percentage of non-union, I'm sure it's at least 10%. So this is a difficult task to be better than that. I mean, I want to learn from Scott to do
well. Yeah, it's definitely higher than 2%. And even though I was involved in a study showing that, and it's also hard to define union sometimes, because that study we did was based on X-ray. We weren't getting CAT scan regular. But it's no question higher than 2%. Maybe not quite 10 here, but I have to worry about it. Let's just say that much.
Another good question, which is often a worry about fusions, Scott. So someone's mentioned long-term problems with the navicular cuneiform joint. Is that something you worry about?
Yeah, absolutely. I have another talk. I didn't have time to put the slides in there, but it's true in the foot and ankle. Anytime you have a one fusion, you can at least count on some adjacent joint increased stress, and probably leads to over a long period of time arthritis. And I definitely see that the navicular cuneiform joint. The good thing is it's rarely symptomatic. I'll have an occasional patient that comes back with some mild discomfort, and we'll send for an ultrasound guided injection. But for the most part, it hasn't been an issue. And I showed you that study, the sports activity, and I'd say, and it's not like a long-term fault, but in general, patients are, get back to a huge variety of activities.
The question about other types of osteotomy, perhaps for Emilio, what about the Ludloff, and what about double osteotomies? I mean, I've got my own thoughts on these. I've published on double osteotomies, and I've done Ludloffs and gave them up pretty quickly. Interested to hear what you think about those, Emilio.
Yeah, I think double or triple osteotomies is, as you saw in my last case, I did a triple on one side. So I think when you have a really truly altered DMAA, you need a double osteotomy if it is with high IMA. So we try to correct every deformity for IMA. You can use, we think, regular osteotomies up to 15 degrees of IMA. Above 15 degrees, we tend to use the MIS, but the MIS won't correct all the pronation. So that's the limit where we change from an MIS distal to a more a promo. And regarding the Ludloff, the problem with Ludloff is that biomechanically it's not correct, because the osteotomy, the direction goes the other way it should go, because when you put weight on, a Ludloff will tend to separate. Besides, the center of rotation of the Ludloff is at the junction between the proximal third and the middle third of the metatarsal, so it's not very powerful. So biomechanically not good, not too powerful. That's why I don't like it.
Question now about imaging, really, and I think this is interesting. I mean, first of all to Emilio, I guess, and then to Scott about the CT. Emilio, how confident are you with the weight-bearing X-ray method that you use, and should we really all eventually be moving to weight-bearing CT? And if that's the case, perhaps for Scott afterwards, how do you quantify the rotation on CT?
If we add the pronation correction in our surgical technique, depending on the technique you will use, it will matter if you want to measure a number of degrees. And even our promo osteotomy uses a qualitative division between you have pronation or you don't. And even there is like no pronation, pronation to be corrected, severe pronation. So it's rather white and black and white. So depending, taking that into account, a regular plain weight-bearing X-ray could be enough. If I had weight-bearing CT, and there's one of those machines here in Santiago, I would be using it. But just to make sure that it is sufficiently pronated to do something about it. So I don't think we need a very specific number. I think we just need to know if it is sufficiently, statistically significantly pronated to do something about it.
Amelia, if I could follow up on that too, you talk about the different shaped heads. We talk about this concept all the time of a chevron type appearance of the head. How do you know that what you're seeing is a shape of the head just due to rotation or pronation, and whether that's or just anatomically it's how a patient is? I mean, the assumption that you're making is that all the morphology that you're seeing depends on the rotation, not just something different or more inherent to the anatomy.
So it's just from experience, because I haven't seen a study which relates the roundness to a different factor. But what we've seen in juvenile hallux valgus, and I think in this we both have seen the same thing, juveniles can have, to me, what looks like true dysplasia. And those I don't rely so much, and many times it's truly a cartilage which is looking just to the other side. And I think those are distorted metatarsal heads, and maybe in those cases it's better to have a true weight-bearing CT scan. But I think the most common cases, still I don't see any published information on another factor which creates a roundness of the shape.
Yeah, well, and Callum, I guess, so to answer my part of it, I went through really quickly. You can look in our article about how to measure it, but you know, the problem is, like I said, you have to, it's complicated because you have to measure it with a reference, and we found that the second metatarsal is the best because you have to measure the pronation with reference to something in the foot to account for, like a flat foot, like Emilio said, could change it. So you have to use, you know, software, you know, measure an axis down the second metatarsal and first, and then I take an angle through that coronal view of the head, and then we compare them basically. And you, but go ahead, Emilio. You're going to say?
Just what I was going to stress out that even you with the weight-bearing CT scan, Scott, what you do when you rotate your Lapidus, you just look at the fluoroscopy and you rotate it until it looks okay, right?
Yes,
So,
exactly. Because I don't have a better, I know what the rotation is for pronation, and we've shown on average you got it corrected by about 8 degrees, but I can't tell you on each individual case. It's how I see it in the assessment.
So I'm getting to the point that maybe we just need some qualitative analysis. Maybe we don't need a number.
If it's pronated enough to worry about it, right?
Well, question about, might be the last question with time, about the pathogenesis. So, you know, what do either of you, maybe Emilio first and Scott, think is the driver for the rotational deformity? And in fact, I'm sure you're both aware there is some literature, isn't there, from Japan? I think there's a paper from Japan about torsion. So there are a group of patients who aren't rotating at one of the joints, but there is torsion within the metatarsal. So what are your thoughts on that?
A true metatarsal torsion is not the main issue here, and you've seen that there are also some articles which deny that torsion. I don't think torsion is something to take much into account. I think this is a ligamentous problem, and as Charlie Salzman, I think I just edited another article which shows a link between flat foot and hallux valgus. It's now more commonly getting into attention. I think it's a ligamentous issue at the midfoot area.
Yeah, me too. I completely agree. So, and I, you know, again, I'm a little biased, but I think it's particularly at the TMT. Although I'm really fascinated to see that cadaveric research you're doing, Amelia, because it may not just be the TMT. It could be either the NC or intercuneiform. But there's got to be failure of the ligamentous stability that allows the rotation. And once it starts rotating, then you're going to have tendon pull distally, whether that's the EHL or FHL, that help just start rotating that big toe around, which also leads to the valgus. So it all goes hand in hand with each other.
Great. Well, look, it's a shame we don't have time for more questions, but we've kind of run out. Thank you very much to both of you for giving up your time for what was an excellent session. Thank you very much also to the sponsors, Osteotech, who have kindly helped sponsor this program, and you've seen their video at the start, and we'll show it again at the end. So we're going to wrap this up now. I think Ian Sharp has 1 or 2 words to say about the next session, but thank you again, both of you.
Thanks for having us, everybody.
Yeah, thank you to those excellent talks there. Next week on the 17th of June, we have a journal club taking place, which is on Morton's neuroma, which will be another excellent session. And then on the 8th of July, another masterclass on the tendon injury in the athlete, organised by Reese Thomas. So at the end of this session, we'll send you an email, which will have a questionnaire on it about how we performed tonight. So it'd be great if you could feedback to us. And once you've sent the email to responded to the questionnaire, you'll then be sent a certificate for CPD points for surgical training. So thank you very much for joining us this evening. I'll leave you now with the video, and look forward to seeing you again next week.